Welcome to Cardiology Section 5. Follow with us as we review heart failure.
All right, so there are four kinds of heart failure. We have left heart, which is composed of systolic and diastolic heart failure. Specifically, left heart, if you're an S3, that means systolic. If you're diastolic, it's an S4. Then we have right heart failure. That means the right ventricle's failed and the main cause is pulmonary hypertension. And then we have high output cardiac failure. The pump is fine. There's nothing wrong with the heart generally, but they have some sort of a metabolic cause that's causing the heart to have to pump really, really fast to meet the oxygen demands of all the tissue. We'll explain these a little bit more. The diagnosis of the heart failures is done by echocardiogram. Often they'll ask you in heart failure of New York heart classifications. This is primarily for systolic heart failure. And what they mean is if you have a New York heart classification of 1, you have no symptoms. 2, you have some symptoms with moderate exertion. Level 3 means symptoms with minimal exertion. And level 4, you have symptoms while you're at rest. There's a lab that you can order. It's called a proBNP. ProBNP is actually a hormone that's released when there's stretch of the atrium and the ventricle in the heart. So when you have excess volume coming back to the heart, all that extra volume causes the heart to stretch. When it stretches, it releases the proBNP into the bloodstream. This then travels down to the kidneys, and the kidneys get this message saying, there's too much volume up here, I need you to pee. So basically, this is the heart telling the kidneys to get rid of the excess fluid. That's why you see the proBNP. So a high level of proBNP in the blood means the patient may have congestive heart failure. And then something that you should know, and this is also in systolic heart failure, low ejection fraction, that's the EF. Patients can benefit from a biventricular AICD. And what we're saying there is that you can actually time when you pace a heart, and you can improve somebody's heart function by pacing them in a biventricular fashion. I'm not sure they're going to ask you this question, but we include it to be complete. And then this is just, we're talking about the ejection fraction here. Normal, 55. Under 40, we call it low. Over 40, essentially normal. So, systolic left heart failure. This means generally they have a dilated thin wall or a very weak ventricle. A heart attack is the most common cause of systolic left heart failure, or the muscle has a heart attack, gets ischemic, no blood flow, the muscle dies, no longer can squeeze, so they get a very weak muscle. There's a condition called Takotsubo that can cause a transient systolic heart failure. It's a release of excessive catecholamines, causes the ventricle to dilate. They have normal coronary arteries, and this usually resolves on its own in a week. Cocaine will cause a systolic heart failure, a dilated, thin-walled, weak left ventricle due to the cocaine causing vasospasm, causing ischemia to the heart. Viral illnesses will do it. Chemo and radiation can also lead to systolic heart failure. The symptoms of systolic heart failure, you got to remember that an S3 heart sound means systolic heart failure. These patients will have dyspnea, PND, post-nocturnal dyspnea, and orthopnea. So PND is they wake up in the middle of the night short of breath and they stand up to walk around. Orthopnea means they're sleeping on pillows. Dyspnea is when they walk. You'll hear rales or crackles in the lungs. This is fluid. And they will have a displaced downward into the left apical impulse. So on the chest, the normal apical impulse is in the midclavicular line, usually about the 5th intercostal space. So their apical impulse will be to the left and downward. So if you were to put your hand and you feel the apical impulse downward and to the left, it's telling you they have systolic heart failure. If you feel the apical impulse in the normal spot and you don't have a lift, then that's just a normal apical impulse. But if in the midclavicular line you feel your hand being raised up, that's an apical lift. That tells you they have LVH. And then if the murmur is actually radiated towards the sternal border, that tells you they have right ventricular hypertrophy. So the diagnosis is an echo. People with systolic heart failure typically have an ejection fraction that's under 40%. The treatment for systolic heart failure, you're going to use when they're stable, chronic heart failure, they're not short of breath, and you're just trying to keep them that way. You always use an ACE inhibitor, a beta blocker, and a loop diuretic. You can add digoxin for systolic heart failure. Digoxin means he'll give you improved contractility and the heart will squeeze a little bit harder. In acute, we use these medications, and I have a table here. Let me see if I can find it. Here we go. This is the best way to look at heart failure. This also is kind of what it looks like with the New York Heart Classification. Here's 1, here's 2, here's 3, and here's 4. So class 1, not short of breath, no symptoms. Class 2, maybe a little short of breath with a little bit with moderate exertion, short of breath with little exertion, short of breath standing still. So chronic stable, they don't short of breath, they have no weight gain or no leg edema. These patients are always on an ACE inhibitor, the beta blocker, and a loop diuretic. This is the chronic treatment for these people that are stable. On the test, you're only going to see this guy and probably this guy. It's hard for them to ask this level in between here. But I show this because a lot of people practice or have been seeing it on rotations and they don't quite understand it, so this will make more sense to you. This guy here in the middle here and this one here, he's stable, but he's got a little bit of leg edema. So what do we do for him? We're going to use the same medications. We're just going to double his oral dose of his loop diuretic here. Then we got this guy here who showed up. He, instead of coming to you at this stage, he comes to you at this stage. So we're going to do the same thing with him. We're just going to double up our oral dose of loop diuretic. We're not going to go double and then double. He's going to either present this guy or as this guy. So he's stable, then he presents like this guy here. We're going to keep doing the ACE inhibitor, beta blocker. We'll just do like we did with the other one, double the dose of oral diuretic. And these guys typically get admitted. These guys usually we can monitor and keep them at home and get them back to here. And then this guy here is the acute heart failure. This is where you guys miss the questions. And the reason is because they always trick you into trying to pick the beta blocker. If they are stable, not short of breath, don't need any supplemental oxygen, our chronic treatment is ACE, beta blocker, and oral loop diuretic. When they become acute short of breath, they have the S3 heart sound and they need to be admitted. We use oxygen on them. We continue the ACE inhibitor. We must stop the beta blocker because it actually makes the systolic heart failure worse at that time. And we put nitroglycerin. And we switch from oral to IV. So for the test, real quick summary, forget these two. The guy is either going to be stable, or we're going to use ACE, beta blocker, and oral loop diuretic. If they become unstable and short of breath, needing hospitalization, then we switch, put them on oxygen, keep the ACE inhibitor, stop the beta blocker in acute heart failure, and start nitro. The oral goes to IV. And we double the dose. So if they were on 20 twice a day orally, they get 40 twice a day IV. So that's the important thing about acute heart failure is if they are in acute systolic heart failure, you must stop the beta blocker and put them on nitro. Once they become stable, we stop the nitro and put them back on their beta blockers. So these are our prophylaxis, prevent them from getting into this stage medications. Once they get into this stage, because they didn't take their medicines or they ate a lot of salty foods, whatever the case is, the beta blocker stops in acute heart failure. It resumes once they're stable again. This question they love to ask almost every time. All right, diastolic left heart failure. This is a hypertrophic or a thick-walled left ventricle with impaired relaxation. The ventricle doesn't relax. So it's a very stiff ventricle. It typically becomes this as you get older in life. You get more and more diastolic heart failure, and it's typically in the elderly ladies who end up having poorly controlled hypertension, and then they have the LVH. So what happens with these patients is it doesn't have the stages like systolic heart failure where they're chronic systolic and then they have the 1, 2, 3, 4. They either are in the heart failure or they're typically not in heart failure. And it's when their blood pressures get out of control that they go into the diastolic heart failure. So they end up with a sudden shortness of breath and elevated blood pressures. The patient forgets to take their blood pressure medicines. Blood pressure goes up. Heart has to work harder. Makes it work faster, needs more oxygen. It needs more oxygen, so it wants to work faster, so it needs more oxygen. And it's a cycle because the heart has to work harder. Then they get nervous. They start feeling short of breath. They start getting stressed. That makes the blood pressure go up even more. And so it's a vicious cycle. So these patients usually go into sudden heart failure. This is associated with the S4 heart sound. They get the dyspnea in the rails, and they're going to have the apical heave because they have that big, thick left ventricle. You're going to put your fingers on the midclavicular line, left side, about the 5th spot, and you're going to feel your hand raising up. That's the apical heave or the lift. We diagnose it, of course, with an echo. The EF is normal, usually normal. And the treatment for diastolic heart failure chronically is we always use an ACE inhibitor. We can either use a beta blocker and a calcium channel blocker to help with the blood pressure. We never use DIG in diastolic heart failure, ever, because they already have a very thick muscle. We don't want to add something that already is going to make it harder for them to contract. So in diastolic heart failure, when they come in acutely, you treat them exactly the same as systolic heart failure that's acute. The same medications, oxygen, ACE inhibitor, you're going to use nitroglycerin, and you're going to use the diuretics. In acute diastolic or acute systolic heart failure, the treatment is identical. So when somebody comes into the ER and they're short of breath and you think it's heart failure, your treatment is identical. It doesn't matter which one it is, and often you don't know unless you do a really good examination and you feel the apical lift or the displaced PMI, or you know their history already. But the treatment for acute heart failure is identical. Oxygen, nitrates, put them on the ACE inhibitor, and diuretics. Once a diastolic heart failure patient is stable, though, they are sent home without loop diuretics. You do not use loop diuretics in chronic treatment of diastolic heart failure because they become dehydrated. They don't have a volume problem, they have a relaxation problem. So this is why we use the calcium channel blockers and the beta blockers to help relax that ventricle so that it'll feel better. So remember, S4, remember that in acute heart failure, it's the same treatment as systolic heart failure. ACE, loop, nitro, and oxygen. Once they're stable, keep them on the ACE and then use a beta blocker, calcium channel blocker. It's really all about blood pressure control. Right heart failure. Pulmonary hypertension is what causes the right heart to fail more often than not. Remember, the pressure in the lungs is very, very low. So the symptoms of right heart failure, they don't have any rails if they have pure right heart failure. The lungs will actually be clear. You'll have JVD and the PMI will be displaced towards the right sternal border, big liver, leg edema. Just remember that the most common cause of right heart failure, though, is actually left heart failure. So if the right heart fails all by itself due to pulmonary hypertension, then the lungs are clear. But if the patient goes into left heart failure, so the left ventricle can't pump, fluid backs up into the lungs, that'll put too much pressure on the right ventricle, that'll cause the right ventricle to fail, then they get the JVD and the leg edema. So the most common cause of right heart failure is left heart failure. But if they have pure right heart failure, it's not the left heart doing it, that the pulmonary pressures are too high, you'll have clear lungs because you can't get the blood in there, and you'll end up with the JVD and all the other signs. So look for anything that mimics the right heart failure. Cardiac tamponade and some of the other cardiac conditions will mimic it, and we'll talk about those. Constrictive pericarditis is one of the other ones that looks like right heart failure. Remember, you have to diagnose it with echo, and this is just showing here's the right ventricle trying to push blood into the lungs. It can't get the blood in the lungs, so the lungs will stay clear if it's pure right heart failure, and it'll just cause backup to the liver and the legs. If the left heart fails, though, it backs fluid up into the lungs. That will then cause the right heart to fail, and then that's why it backs up to the liver and to the legs. So left heart, most common cause of right heart failure, but if it's pure pulmonary hypertension, this is fine, then the right heart fails, the lungs are clear. These are all the causes of pulmonary hypertension. Now, high output cardiac failure, there can be something before they get the high output cardiac failure. They could already have a cardiac problem, but we're just going to assume somebody has a normal heart when it occurs. So a person who has a normal heart when they get high output cardiac failure, what's occurring is the heart's not having a problem. The body is having such a high metabolic demand for oxygen, and what I mean by that is blood means oxygen. The more blood you move around, the more oxygen you're moving around to the body. So somebody who gets what's called beriberi or a hyperthyroid storm or very severe anemia or maybe a shunt, the body's going to start asking for oxygen to compensate for this metabolic problem. The easiest way is to just use arbitrary numbers. Let's say the heart pumps 20 units of blood at the very maximum that it can do. And so at rest, the body only needs 5 of those units. It gives you a reserve of about 15 units of oxygen. So we can exercise and run extreme amounts of distances or heavy weights and things like that and exceed our 20 units of blood that we can pump. That's why when we get done exercising, we still breathe hard and we're trying to recycle, push oxygen around and fill, the tissues that need the blood with oxygen. but then we're able to stop and recover. Well, what happens with high output metabolic state is somebody with a hyperthyroid storm, the tissues get so metabolically active that they're going to request more than 50 units of oxygen, whereas the heart can only push 20. So the heart is going to just pump as fast as it can for as long as it can to try and meet these metabolic demands that far exceed what it can normally do. So what happens is the heart just pumps and pumps and pumps and pumps as fast as it can. Eventually it gets tired like all of us. And so then it turns into what looks like a systolic heart failure. They get the shorter breath, the rails, and you have to treat it like systolic heart failure. So high output cardiac failure is a metabolic demand gets severely increased. The heart tries to meet that demand. It's normal, but it can't meet the demand. So eventually it gets exhausted, the walls thin out, dilate, and it looks like systolic heart failure. So initially they're just tachycardic and the heart's pumping really, really fast, trying to meet this extra demand here. Eventually it gets tired, the walls thin out, kind of heart starts pooping out, and eventually you end up with systolic heart failure, and so you're going to treat it like acute heart failure, and you got to correct the underlying cause. The thyroid storm, the anemia, the shunts, or the beriberi, which is the thiamine deficiency. Then we get cardiogenic shock. Cardiogenic shock is defined as hypotension with tissue hyperperfusion despite adequate left ventricular filling. So we're saying that the heart and the ventricle is getting the blood it needs, but it's not able to actually pump it forward and out to the body, to the brain, to the tissues. So that's defining cardiogenic shock. So the ventricle fills with blood, it just can't push it out like it should. A heart attack is the most common cause of cardiogenic shock. Lack of blood flow to the coronary arteries can stun the muscle, so they go into a cardiogenic shock. We have some ways of treating it. You can use your medications first when the pressures are dropping in cardiogenic shock fluids. Then we go to dobutamine, which is the drug of choice for cardiogenic shock. If they're still hypotensive with dobutamine, you add the norepi. And remember that there's a mechanical thing called a balloon pump that you can place in for patients who have cardiogenic shock that can help pressure support. The balloon pump is placed in the descending aorta, and it actually inflates during diastole, and it actually pushes blood backwards to the coronaries. So it improves oxygenation both during systole and during diastole.